A privilege to be here. Thanks for organizing committee for inviting me. I'm going to present my talk on total hip arthroplasty in fracture neck femur by the piriformis sparing posterior approach. As you all know, the risk of THR dislocation higher in a patient with a fracture neck or femur compared to the patient who have a THR for the region like osteoarthritis hip. Also, the posterior approach in fracture neck femur also have a higher chance of dislocation that literature suggests. And in literature, the total hip arthroplasty in fracture neck femur is a much higher dislocation rate of dislocation up to the some literature. It is a 14%. In 2016, the extra hip unit in UK popularized the spare approach for the hip arthroplasty, in which we spare the piriformis in obturator internus tendon and repair the obturator externus. In our cases, we did with this modified spare. In a spare approach, we spare 4 tendon that is called the quadriceps coxa. The incision line is through the inferior gemellus, but we sacrifice, in modified, we sacrifice the inferior gemellus and make in the capsule the L-shaped incision. So in my experience with this approach, in the two lateral position like a posterior approach, the skin incision and subcutaneous dissection. After in the line, cutting the tensor fasciolata with a skin incision, identifying the piriformis in the obturator internus muscle. And after the abducting the head, placing the Hohmann retractor to retract the piriformis obturator internus away from the operative fluid, exposing the capsule. And with the help of cautery, we cut the capsule in the line and cut also the obturator externus and the femoris quadratus along with the capsule. So it is a capsulotomy. And by the adducting and internal rotation, we delivery of the femoral head. It is a case not of fracture, but is a case of osteoarthritis hip, in which the pics. So this is a acetabular exposure. The acetabular exposure is quite good, showing also the piriformis from upper superior side. Acetabular reeving, broaching of the femur. After the component placement, complete placement of the acetabular and femoral component with intact piriformis tendon and obturator internus muscle. So here is a video in which showing the piriformis and obturator internus muscle are intact, tendons are intact. So after there is a complete repair of the capsule and tractional rotators to the GT, transosseous sutures. So this is a case number 1 of 50-year male, in which having the right side the fracture neck femur, showing with this approach total hip arthroplasty. So the second day, the patient walking video, patient is not having pain and walking comfortably. And the day 3, the patient is walking without any support walker. Or in the case number 2, there is a 57-year female, a fracture neck femur. And is a pre-op X-ray showing, and a post-op X-ray of immediate post-op X-ray after the total hip replacement with this approach. And is the day 2nd post-op video, in which the patient not having pain and comfortably walk with the help of walker. So we regularly operate the cases of fracture neck of femur by total hip arthroplasty of hemi replacement with the piriformis sparing approach. And in 2 years of experience, we have any type of incidence of dislocation. What the literature said about the piriformis sparing approaches, the piriformis preserve the piriformis membrane may cause the less visualization of superior portion of the acetabulum. However, the anterior inferior capsule release and proper placement of femur with flexion, internal rotation, adduction make it possible to achieve highly reproducible results. In second, in other article, the superior transfer reconstruction approach is safe, has demonstrated excellent early to mid-term efficacy, profiled outcomes, and unobstructed acetabular and femoral intraoperative view, facilitated the optimal implant positioning and contributed to excellent dislocation outcome in combination with the piriformis preservation. Aside from being the less injurious to the piriformis muscle, the piriformis sparing approach offered a same long-term functional benefit as standard posterior approach at 10 years. Changing from posterior approach to piriformis sparing posterior approach in a patient with femur neck fracture treated with hemiarthroplasty resulted in a more than 50% reduction in dislocation and reoperation rates. In other article, when treating the displaced intercapsular fracture, patient with a hip hemiarthroplasty spare approach appears safe, may provide not only the joint stability but also the superior functional recovery, as demonstrated by an increase in return to pre-injury level of mobility compared to that of standard lateral approach. So better than lateral approach in hemiarthroplasty cases. The preservation of piriformis tendon during the posterolateral approach in THR is a possible surgical technique that is easy to use, reproducible in both arthritic and traumatic condition. It follows an anatomical intermuscular plane and permit the full exposure of both proximal femur and acetabulum. Compared to the literature, preserving the piriformis tendon seems to be superior to repairing it in terms of dislocation of THR. So, take-home message is piriformis sparing approach, safe and minimal invasive technique, less post-operative pain and early rehabilitation, improved stability, because the piriformis muscle and obturator internus tendon, it also secondary stabilizer in the abductor along with the abductors. So improve stability and less risk of dislocation. It is an alternative to conventional posterior approach. Thank you.
Thank you. And I request Dr. Harish, you may be seated in front. And now I request Dr. Shibam to come up for his presentation.
So I thank to the organizers, and this is one atypical case which presented to me in 2019, and I would like to have some interaction with the experts there on the TICE. So this is a 35-year male presented in 2019 with a complaint of pain and deformity over the left hip for 2 years after sustaining a road traffic accident and probably a dashboard injury. And he was managed elsewhere for a fracture shaft of tibia, for which interlocking nail was done. The examination of hip was very particular for posterior dislocation of hip. There was shortening, as well as when we examine the knee, there is a posterior sag, a grade 3 posterior draw, a dial test, which is more in external rotation, valgus laxity, with all McMurray's and Lachman's were negative, but knee range of movement was terminally painful, hip was quite painful. So when we did the X-rays, this is the pre-op radiology of the left hip, and X-rays of knee are not that available, but there was kind of not much of articular damage, and instability can be deciphered. So the next investigation or something else you would like to plan? I think we would like to go for an MRI, both hip and knee. We'd like to see the CT. So let's see the CT of the hip. This is the coronal view. We can see something in the native acetabulum. It is superior and it has gone posterior, but native acetabulum is there with some amount of thin wall between the two acetabulums. If you review the X-ray again, this was the X-ray. A native acetabulum is there, but there is a thin bone and there is a false acetabulum, posterior and superior. If you see the MRI, the clinical diagnosis was enough for getting it to be a medial corner injury, an MCL injury which is almost 3 years old, and a PCL tear. So this patient came to me walking in pain and instability with the brace on. So a neglected 2-year-old posterior fracture dislocation of left hip with femur head fracture Pipkin type 2 with a complete PCL tear with grade 3 MCL injury. How would you like to proceed in this case? Which pathology should be addressed in terms whether it should be hip or knee? These were the questions which were going through my mind. So I would like, how is your thought process in dealing with this case? How would you like to go over it, sir, hip or knee? Anil, sir.
You're asking me?
Yes.
So first of all, we need to decide if I handle knee, will hip interfere in my rehabilitation? If I decide hip, will knee interfere in my rehabilitation? So I think I will handle hip first.
You will do the hip first.
Yeah. Knee I can handle with the brace, no issue, while rehabilitating. That will be my thought.
Any
for the
other
time
difference
being.
of opinion?
Knee can be managed by the brace also.
So
Meanwhile,
knee
you
was
have
being
to
managed by brace only. There is an
Temporarily.
instability
That is-
and there is a pain.
See,
there.
Temporary,
That
temporary.
will be, that is temporary. Of course, we will operate after that. But initially, you have to go for the hip because now the pain is more in the hip. If you address the knee, he will not able to walk. But if you address the hip, he will able to walk with the brace.
No, would you like to manage it simultaneously?
No, I would not.
No.
It will become a huge surgery. You see, hip
I-
itself is a huge surgery.
Of course, no.
Think of chances of infection on table. You do such a
Yes,
long
Dr.
surgery.
Pankaj.
My concern is the frankly unstable knee.
Yes.
And I'm a posterior approach surgeon.
Correct.
I'll struggle with my dislocation, preparation, positioning.
When you are not very sure that how the stabilum is.
That's correct. So I probably will address the knee first, and then get some stability there. Patient is already walking with pain, but with the knees being so unstable, I may add to the injury. That's my concern. So I'll do knee first and then go for the hip later.
So dual mobility going inside the brain, we have two school of thoughts and that has been exposed. Yes, Dr. Sani, you want to say something?
PCL injury, there are likely chances to the popliteal artery. I have seen 2-3 cases that this
So this is 2 years old.
It's a
No
3
distal
year, it is 3
neurovascular.
year
okay,
old.
but it is unstable, and
Yes.
I think addressed to the first knee.
Sir,
and then-
basic
is-
concern,
it is
Anil
all-
sir, basic concern is, does the instability of the knee contributes to the instability of hip when we are not sure too much about the hip reconstruction?
So my question to Pankaj was, how does PCL interferes in my acetabular placement?
It was PCL with medial collateral ligament injury
Yeah.
and frank instability grade 3. So I was just wondering, when I am dislocating my hip and putting pressure on the knee, then why not I do my knee first, and I will also risk some pressure on my neurovascular bundle because I don't know how's my posterior lateral corner also.
It
So if
can
you do
be-
hip, there are various ways of dislocating. I never ask rotate the hip. Always as a hook.
Sure.
With the hook, always will ask.
So if you have a
But,
hip
but
like
it can be
this-
vice versa. It can be vice versa. If you do hip first, then if you do the knee first and then hip second, then it may be chances your knee surgery will be
Sir,
loose or getting loose.
Sir, my thought process
Could be
was
wider.
that I am a posterior approach surgeon, and this knee is grossly unstable. If I'll replace, I'll definitely reduce the pain. But once I'll do for rehabilitation and weight bearing, the moment this patient slips, my hip will be at a jeopardy when I am not very sure that what reconstruction. Now, next question comes, when you see an acetabular like this, any special preparation for acetabular component you would like to have in your armamentarium?
We could not see
can I
the
add
CT
something?
very carefully because if there is a loss of periphery, we'll keep our augments ready if it is so. We could not see the CT very carefully, so because the column seems to be okay, the head is out. In this transfer, see, anterior and posterior both are visible. How is the superior one in 360 degree 3D with
Sir, that is missing. That
head
is missing.
subsection image? That is the most helpful thing.
That superior part has been probably made by pseudoacetabular by the continuous mobilization of the head over there. So there is a thin rim of bone posteriorly, but there is a bone which is superior laterally missing.
Missing, that's right. So keep an augment ready for that.
Right.
Superior augment. You go ahead.
So I continued with the philosophy and I decided to do in a stage procedure and will like to, because the patient is already there in pain, not being able to rehabilitate. So I continue with the plan to get the knee first, to get the stability first at the knee. We did the diagnostic arthroscopy, get the graft harvest from hamstrings for PCL on a contralateral limb, and arthroscopic PCL reconstruction, an MCL reconstruction with an ipsilateral hamstring graft in the same sitting, leaving the knee at least to be stable and wait for a while. And this was the story in 2019. And this is what arthroscopic reconstruction was done to gain the medial as well as anteroposterior instability. It was dealt. Then there was COVID outbreak. This was a poor patient. Now he had a good range of movement. He came to me after getting the proper logistics for hip to be done. So knee and range of movement, now the knee instability issues have been done. And then this is how the hip was done, managed through the posterior approach, getting the dislocation neck cut there. There was a thin wall there. I could get the purchase of my screws in the superomedial wall, get the offset right, could check the stability right. Though there was a bone defect superolaterally, I was thinking to put some graft, whatever was available was applied. This is 6 months and 1 year follow-up. The patient is doing well. The defect is also healing. And so now this follow-up, say almost hip surgery 2 years and for knee surgery 4 years, no limb-length discrepancy, hip and knee range of movement full, no instability, Harris scopes and VAS is normal, all those knee scoring system is right. This is what the patient is able to get the balance, no pain, no instability. Thank you.
Thank you. Please have a seat in front row. And now the house is open for queries.
Can I ask a question?
Yes, sir.
To Dr. Uttam. Dr. Uttam, you said the failure rate of fixation in intertrochanteric is up to 56%.
Yes, sir.
Doesn't sound to be practical.
But
To other panelists also. 56% failure rate with intertrochanteric.
I have quoted the literature where it is there.
And
But it was the literature was in 1989. So the fixation method was very difficult.
That's right.
And
Maybe DHS. That's right.
So that is the
And
reason.
secondly, see, shall we go back with the idea? Because you said, as per literature, bipolar fixation is superior to fixation
Yes, sir.
in intertrochanteric. Can we go back with this message?
I think-
Rather than so, what I want to understand is, for our benefit of our delegates, I think is the personality of fracture on which we will decide whether to do bipolar or to do internal fixation.
Sir, basically what the study is the arthroplasty at the age of 75 or more than 75. So at that stage, the bone is weak, the osteoporotic, and in that scenario, bipolar is definitely better than the THR because the dislocation rate is very, very high in THR group. In more than 75, I was asking about the more than 75. Of course, the patient is young, then THR is good.
See, I think if I were to convey, I would think that if the fracture line is such, going right up to the subcapital area or going to the neck area where I expect my purchase to be poor, then only I should think of doing a hemiarthroplasty or THR, whatever we are thinking of. But if there is a good bone chunk, if you go by Rockwood Green, still says even at 80, 85, one should do fixation.
Sir, it's a debatable topic. Well, the both methods are described. Although the complication rate of arthroplasty is also there. So it's a debatable one. But in most of the arthro, they believe if the age is more than 75 in osteoporotic and bad fractures, that bipolar is definitely a very good option right now.
Whenever you think that fracture is not going to unite,
Exactly. I have
whenever you think fracture is not, and if at all you are thinking of doing arthroplasty, so either do bipolar or do dual mobility.
Dr.
dual
Kumar,
mobility is fine. Dual mobility is
so
better.
it is fracture personality based, not the age. This is what I want to convey.
Sir, I fully agree with you.
Yes.
It is not the fracture, it is not the age. It is personality of fracture.
It is the personality of fracture.
Yes.
If you think fracture will not unite, if you try to fix it,
So if
even in the best.
may I add
Agreed.
something to this?
Yeah.
If there is a lateral wall comminution, if there is a comminution in the superior neck and the posterior neck, and patient has severe osteoporosis, trivial fall leading to trauma, you should think of doing an arthroplasty. But if the fracture is stable and there is not much communication, the lateral buttress is intact.
Sir, I am talking
See,
about the unstable fracture.
Just
That-
allow
no.
me to finish.
Dr. Pankaj, with intramedullary devices,
Yes.
this is not a big game now. With intramedullary devices, you need a big chunk medially
Yes.
and shaft, that's all.
That's correct.
The lateral wall, we are not much worried. With these intermediate devices now.
So a doubtful
Can I add
osteosynthesis probably is the answer. If you are in doubt,
Can I add something,
your
sir?
work is not going to
I
work.
think we have to also consider the fact whether
Yes,
I will be
that is
able
the
to
point.
mobilize the patient after the surgery. And if so many times a patient with so much of OA, with so much osteoporosis, overweight, with fixation, he or she will be in bed for, you won't be able to mobilize for next maybe 6 weeks.
It
So
again,
in those cases,
it
and
again
I'll-
boils down to personality of the fracture, not age.
as well as
Again,
the
I'm coming
patient,
back the
as
same
well
thing.
as the
Age is one
overall
of the
picture
criteria.
patient.
It is not the age. It is the personality of fracture. Like he said, fracture going right up to the neck. The proximal fragment is so short, osteoporotic, that you are not sure of fixation. Then only, not the age.
With better intramedullary devices, like the TFNA nail has come, so there was DHS and then PFNA2, and with TFNA2 it has got the advantage of DHS also because it's locked with this thing and it gives a better construct. Even in grossly comminuted fracture, you can make the patient walk the next day. So that's why the controversy of doing bipolar and fixation, it is going more in favor of fixation because of the better intramedullary fixation.
Yeah, why I'm saying, because every OT we have one hip fracture to fix. Every OT. He will endorse it. He's in the same hospital. And we have been doing fixations. Very rarely we do bipolar. Then only, when do we do bipolar? When the fracture line extends far too proximally and I'm not too sure of my fixation into the head. That's all. Then only. And we never ask the patient for bed rest in PFN and TFN. We never ask them to bed rest.
I have a question for Dr. Harish. What are the tips and tricks to protect piriformis in your sparing exposure?
Sir, when we open, cut the bursa, the glasting tendon, as we read in my book, the glasting tendon.
Keep your mic.
Hello?
Yeah.
Yes, sir. Sir, at the quadratus femoris muscle attachment in certain side, there is a branch of medial circumflex artery, trochanteric branch, that you usually at a time of arthroplasty or doing bipolar, we have to cauterize it. That is at the superior level of quadratus femoris. So that is a intersection line where we put a artery and dissect the outside the rotators like piriformis or obturator.
While acetabular ribbing, how I am going to protect?
Sir, abduct, okay sir. At the time of acetabular review, we abduct the hip, abduct the femur, and keep the femur at the flexion of 60 degree flexion. In that position, and with levering inside Homan, along with the abductor, it remove the field from the field of reticule.
Okay, thank you.
Basically, you have to put the Homan, basically you have to put the Homan below the piriformis and then lift it up. Then it will be straight.
Sir, abduction of the limb.
Abduction is more important to relax the piriformis.
Relax.
Agreed.
And then flexion.
But once you internal rotate, it will again tighten. So you have to reduce
keep the limb in a neutral position.
Yes, that is the main point.
I have two concerns with this approach. Like the first thing is that if you are not able to dissect properly around the trochanteric area, there is a possibility for putting the stem in varus, number one. And number two, exposure of the acetabulum on the anterior aspect. I think it will be a bit difficult if you are not releasing the piriformis.
If you are facing a difficulty in acetabulum exposure anterior side, we have to release the insertion of the gluteus maximus at the proximal part of gluteus maximus, and that is easy after that. And second point, sir.
Chances of putting the stem
Let
in
us
varus.
move to
Stem
next
in
session.
varus. Sir, obturator more superior and medial insertion of at the GT tip, and anterior insertion of the obturator internus. It's not to create any problem at a time of putting broaching femur or
Anytime we can be content to Mohs approach if there is much problem.
Can we have a photographic session?